Hi guys, I'm Dr. Sunil Sharma, consultant ENT head and neck at Rajasthan Hospital and authentic ENT and head and neck center, Ahmedabad. Now we will talk about facial nerve palsy and management. General introduction. As you know, there are 12 cranial nerves, so I'm just talking about general things. That cranial nerve 12. Total number of cranial nerve is 12. Pure sensory 1 to 8. Pure motor 3, 4, 6, 11 and 12. Mixed nerve is 5, 7, 9 and 10. Thinnest and longest intracranial course is dorsal origin nerve, that is trochlear. Thickest intracranial nerve is trigeminal nerve. Longest and thicker extracranial nerve is vagus, that is 10th. Shortest intracranial nerve is hypoglossal and shortest nerve is olfactory, that is nerve 1. Thinnest overall nerve is 6th, that is abducent. The longest nerve of body is sciatic nerve. Now we will talk about facial nerve and its management. Introduction. Facial nerve is unique complex in terms of form, function and physiology. Facial nerve, the seventh cranial nerve, is involved in congenital anomalies and degenerative disorders, affected by a range of acquired pathology from infectious to neoplastic condition. A thorough understanding of the embryology, anatomy, physiology enables the physician to accurately diagnose and treat disorder of the facial nerve. This is facial nerve divisions and function. You know, there is branchial motor nucleus that is situated on the pons, which express the muscle of the facial expression, posterior of digastric muscle, stylohead muscle and stapedius muscle supplying. The visceral motor is mainly parasympathetic in nature, mainly made for lacrimation, submental gland, sublingual gland secretion, nasal mucosa and mucous membrane. The general sensory functions are sensory to, that is auricular, external auditory canal and tympanic membrane. The spatial sensory, as you already know, the taste sensation of anterior two-thirds of the tongue. Now this is having about 10,000 of nerve fibers which having intracranial origin, the pons, which exist from the brain stem. And firstly there are two roots which form the facial nerve. Next the nerve from the geniculate ganglia and give rise to that greater petrosal nerve, chorda, next to it chorda tympani, and finally exist from the stylomastoid foramen. The spatial sensory provide the senses of anterior two-thirds of the thumb. Parasympathetic supply the glands of the submandibular, nasal and lacrimal. The course of facial nerve very complex. They are very branching and transmit a combination of sensory, motor, parasympathetic nerve fibers. Anatomical course of facial nerve divided into two parts, intracranial and extracranial. Extracranial course exists from the skull base, facial nerve superior to anterior to the outer ear. The first extracranial post arises in the posterior auricular nerve. It provides motor nerves to stem of the muscle around the ear. Immediately distal to the motor branch are sent to posterior belly of the digastric muscle to stylohead muscles. The main trunk of the nerve, now termed the motor root of the facial nerve, continues anteriorly and inferiorly in the parotid glands, which finally divide into 5 branches: temporal branch, zygomatic, buccal, margin and cervical branches. These are the 5 branches of the pes anserius. Now as you know, in this picture there is, you can see afferent division. You can see that greater petrosal nerve supplying the spinopalatine ganglion, stylo, that is chorda tympani arising from stylomastoid, just 1 centimeter of the stylomastoid foramen, and stapedius arising from the tympani, that longitudinal segment of mastoid portion. As you know, so origin in the internocoustic meatus, you can see entirely facial nerve, just below is cochlear nerve. This transverse is called as Bilswa, that transverse ridge, and this superiorly dividing the facial nerve to the superior vestibular nerve is the Bilswa. Clinical reversal the damage of the facial nerve. You can see facial nerve is wide range of function and damage anywhere affect the taste, muscle expression and the salivary gland secretions. The most common cause of intracranial lesion of the facial and middle ear pathology, such tumor infection. If no definitive cause can be found, the disease term is Bell's palsy. Extracranial lesion may be parotid injury, infection to the nerve, trauma, or idiopathic, that most commonly is Bell's palsy. As you saw, etiological factor, there may be laceration, stretch, and compression. Main causes of upper motor neuron palsy is cerebrovascular accident, trauma, tumor, infection, multiple sclerosis. If you talk about lower motor neuron lesion, is systemic infection, Bell's palsy, varicella zoster, Lyme disease, HIV. Middle ear may be otitis media and cholesteatoma. Lesion of skull base may be fracture, infection. Parotid lesion may be tumor or trauma of the facial nerve. There are causes of bilateral simultaneous facial palsy, Guillain-Barré syndrome, Mobius syndrome, sarcoidosis, Lyme disease, skull base trauma, infectious mononucleosis, cytomegalovirus, and HIV in botulinum toxoid. These are the common causes of bilateral simultaneous facial palsy. This is taken from Setalov Comprehensive ENT and Head and Neck book. And if you see the diagnosis, how you diagnose the facial nerve, first we have to take the proper history, and we have to rule out that all histological diagnosis, like we have to do topo diagnostic test, MRI, CT scan, electrophysiological testing, and proper history taking. Most of the time, if you are taking proper history, you will come to know all about the proper diagnosis of the facial nerve. If we see the DD of the facial nerve infection, mostly if you see infectious, maybe ASOM, CSOM, herpes zoster, malignant otitis externa. It may be trauma, if any history of trauma. It may be central cause, brain abscess, pontine glioma, poliomyelitis, multiple sclerosis. It may be intracranial cause, acoustic neuroma, congenital cholesteatoma. It may be extra malignancy, parotid injury, idiopathic, that is most commonly Bell's palsy or Malcolm Rosenthal syndrome. Systemic may be tuberculosis, diabetes, TB. If we have to diagnose the lower motor neurons or upper motor neuron palsy, if you see clinically, in lower motor neuron is complete palsy of the forehead up to the chin. There is complete paralysis of the face. In supranuclear palsy, this supply from the, if contralateral bundle is gone, so there is contralateral facial palsy. But forehead is spared because of the ipsilateral supply of the supranuclear part of the nucleus which supplying the forehead. So upper part of forehead is spared in supranuclear palsy, not in lower motor. As you see, lower motor is completely gone. Now there is grading of Hausmann and Brexman classification of facial nerve injury. It may be grade 1, that is normal grading. Grade 2 is slight dysfunction. If you see overall, that is no obvious motions, no obvious palsy. If forehead moderate to good function, eye complete closure with minimal effect, mouth slightly asymmetry. In grade 3, moderate dysfunction, forehead slight, that is obvious injury, eye complete closure with effort, you can see. Grade 4 is moderate dysfunction, forehead is incomplete closure of the eye, and forehead there is, you can see, asymmetry, and asymmetry with maximum from mouth on. Severe dysfunction grade 5, that eye is incomplete close even though maximum effort, and grade 4 is total paralysis. If you see the classification of injury, there is Seddon has classified neuropraxia, axonotomesis, and neurotomesis, where further Sunderland has classified the grade 1 to 5. One is neuropraxia, that is conduction block, axonotomesis, the injury of the axon, and third is injury of the endoneurium, fourth one is injury of the perineurium, and fifth one is injury of the epineurium. There is added classification of 6, that is mixed injury, that is traumatic injury in Sunderland classification, that is grade 6. If you see this bundle as mentioned, the epineurium, endoneurium, and injury according to the type of the injury. Now we have to do the topographic test of the facial nerve. Schirmer test, that is lacrimation, and that suggests the injury at the level of greater superficial petrogena. If stapedial reflex is gone, that stapedial muscle contraction, that branch that is in the styloid, longitudinal part of the styloid, mustard part. And electrogastrometry, we can identify the taste that injury above the origin of chorda tympani. And salivary secretion is same for chorda tympanic level of facial injury. If you see electrophysiology test of facial nerve, there are four tests: nerve excitability test, maximum stimulation test, electroneurography, electromyography. Net test is lowest stimulation effect of facial twist. If there is difference more than 3.5 milliampere, you could diagnose. By maximum stimulation, if you are giving 5 ampere current both sides, there is marked diminished facial contraction on that side, that suggestive of the facial palsy. Electroneurography is most important. That says the compound muscle action potential. If it is less than 10% of healthy side within 2 to 3 weeks of facial palsy may predict poor recovery. Decompression can be considered. Electromyography, the spontaneous voluntary muscle action potential, that fibrillation potential within 2 weeks of facial predict incomplete recovery in 80% of the cases. Electroneurography is considered the most valuable prognostic indicator among current electrophysiological tests, and the main indicator is acute onset complete facial palsy. Both the percentage of amplitude reduction and rate of the degeneration have been used as prognostic indication of facial nerve recovery. In idiopathic palsy, degeneration of more than 90% within 40 days of complete paralysis indicate a probable poor recovery in 50% of the cases. Electroneurography does not appear to be useful in Ramsay-Hunt syndrome because of multiple sites of injury. Fish has recommended surgical intervention within 3 weeks in patients with traumatic injuries has resulted in more than 90% amplitude reduction by electroneurography within 6 days of injury. Great care has to be taken interpreting these data. Although there is good correlation between the natural history of idiopathic palsy and electroneurography finding, there are no definitive data on natural history of facial nerve injury due to other causes. The assumption of electroneurography data is valid regardless of whether the paralysis was the immediate or delayed onset cannot be justified from the nature. This is taken from the Scott Brown. Electromyography, that is polyphagic motor uterine potential, indicate regenerative process, and surgical intervention is therefore not indicated in cases close follow-up studies of nerve regeneration is advocated. Fibrillation potential indicate lower motor neurons degeneration but viable motor end plate. Surgical exploration is therefore indicated within view of achievement nerve continuity, either by end-to-end anastomosis, interposition, grafting, rerouting, or reinnervation technique. Silence on EMG, no electric output, indicate long-term degeneration and suggests the muscle has been replaced by fibrous tissue. In this case, static or dynamic microvascular innervation, free muscle transfer, or muscle transposition, facial reanimation is indicated. Now, how to care about it? The eye protection is must, so you have to protect the eye. Eye care focus on protection of cornea from dehydration, drying, and abrasion due to sufficient eyelid closure or tearing eye. Ointment is proposed during day and night, supported by watch glass bandage during the day or night. Physiotherapy. There are very few controlled trials available of effectiveness of physical therapy of facial palsy. It is randomized 50 patient Bell's palsy and House proxemic classification 6. You can see the physiotherapy is necessary. Steroid is highly effective in Bell's palsy and other herpes zoster oticus or Ramsay-Hunt syndrome. So you have to start within 72 hours of the therapy. This patient, as you shown in this picture, have traumatic facial injury followed by facial injury. So I have done this all three nerve grafting, interposition graft, and primary closure of face. So all three nerve, that temporal, zygomatic, buccal, I have sutured or applied glue. After that, patient is absolutely fine. This case, you can see in this picture, first one that is approximation, second is interposition graft, third is again interposition graft. And after this closure of this wound, this patient is completely recovered, full case. And this case was published in Northeastern Medical Science 2008. And this is the publication by me. You can see in this picture, and this is all about this patient also developed Frey syndrome, and after doing the surgery this is completely resolved all symptoms. And so this is, thank you so much.
बंद करो।
खोलो।
हाँ ये सही हो गया।
अभी बंद करो, खोलो
खोलो
बंद करो, टाइट बंद करो बेटा। बहुत अच्छा, खोलो बंद करो।
उस साइड घुमाओ तो
कोई मेरी तरफ देखो, मेरी तरफ, इधर चलो मैं उधर आ जाता हूँ, उधर आ जाता हूँ। चलो बेटा, खोलो बंद करो, बंद खोलो।